have a celiac disease. And in a celiac disease, somebody will present with anemia, weight loss, steatorrhea. Steatorrhea basically is you are passing loose stool that is mainly full of like lipid, full of fat, fatty stool. That's what we mean by steatorrhea, fatty stool. And when you look at the microscope, you'll see blunting or flattening of the small bowel villi. Remember, the small bowel are what we call finger-like projection, the villi. So when you look at them, they're flattening out. And then when you look at the wall, you see increased lymphocytes and plasma cell in the lamina propria. And then there is increase in triepithelial lymphocytes. And then the crypts. There is hyperplasia. Crypts basically will be where the glands would be. So, and this one is caused, this celiac disease is caused by hypersensitivity to gluten, a constituent of wheat, rye, or barley. We think that is what causes it. So somebody has, so sometimes people, of course, with this celiac disease, probably they'll be told to avoid wheat products, so they stop taking anything that has wheat in them, because we think there is gluten, which is a constituent of wheat, rye, or barley, and some people become hypersensitive to it, and that is what leads to celiac disease. So it can also known as gluten-sensitive enteropathy. You can call it celiac sprue. You can call it idiopathic steatorrhea. So those are some of the names that they cannot mean the same. So in this case, usually what causes is that the patient's own immune system damages the small bowel mucosa. So it is hypersensitive to those gluten. Then those antibodies start destroying the small bowel mucosa. It starts destroying its own mucosa. So this one results in malabsorption syndrome with very variable symptoms. So basically, if you remove the villi, then the surface for absorption is reduced. So you end up with problem with absorption. That's what we call malabsorption, bad absorption. So you are not absorbing nutrients as you should. Remember, absorption, mostly digestion and absorption mostly will occur in the small intestine. And one of the things that help the small intestine to be able to absorb is because of those finger-like projections, the villi, which increase the surface area for absorption. And so when those ones are affected, you will have malabsorption. So diagnosis is usually confirmed by endoscopic biopsy of the proximal small intestine. So you do OGD all the way to the duodenum, and then you do a biopsy. You remove a small tissue from the wall of the duodenum, and then you take it for histology. That is how a diagnosis is made. And so when you look at the microscope, you will see that there is infiltration of lymphocytes within the wall. And they are mainly T lymphocytes and represent a cell-mediated immune reaction to gluten. And patients who have celiac disease, they are at risk of developing lymphomas and adenocarcinoma of the small bowel. So people who have celiac disease, they are at increased risk of developing lymphoma or adenocarcinoma of the small bowel. Usually, carcinomas of the small bowel or small intestine is rare. But when you have celiac disease, it tends to be a predisposing factor to developing those. So it's a most important cause of primary malabsorption occurring in temperate climate. Temperate climates will be those climates especially that has all those forces on winter and so on. So mostly it will be those developed countries and so on. But I know you people are more recently from geography, so you probably know better that I do those temperate climates. But of course, it can still occur even in other areas. So what that's what's called giardiasis, basically an infestation by a parasite called Giardia lamblia. So this one will present with diarrhea and also steatorrhea. That is basically, stool that is full of lipids or fatty stool. So in this case, in giardiasis, the mucosa is normal or inflamed. So it may be normal or inflamed with villus atrophy. So those villi will be atrophied. You have also sickles, so you'll be able to see these parasites. Sickles, and they appear like a sickle. So sickle-shaped parasitic Giardia lamblia organism on the epithelial surface. So they'll be on the epithelial surface. So this Giardia lamblia is a protozoan parasite which causes diarrhea. So protozoa, for example, another parasite that is in that group of protozoa will be the malaria parasite, the Plasmodium falciparum, or all those Plasmodium ovale. Basically, Plasmodium that will cause malaria is in the same group. This one also is a protozoan, this Giardia lamblia. So, and this organism, this Giardia lamblia, is spread via contaminated water and is more common in institutionalized and immunocompromised patients. So basically hygiene. So if there is contamination of water and so on, so poor sanitation. And of course, people who are institutionalized. So people who are maybe in prisons who are in hospital or who are sick, who are immunocompromised, those are people who are likely to develop this giardiasis. In normal people, they are likely to, it's rare. And to be able to confirm a diagnosis in this case, you have to do a biopsy of the small intestine. So you take a small tissue from the small intestine, the wall from inside, then you take it for histological investigation. Then you'll be able to clinch the diagnosis. Of course, you have many other things that can affect the intestine, including congenital anomalies like atresia. Atresia basically is narrowing, basically did not form well. Stenosis, narrowing. So atresia basically there is no lumen at all. Basically, it's atretic. But stenosis is narrowing, which can be, you can have also what we call metadicaculum. If you go back to development of the intestine, remember there was a connection between the ileum and the umbilicus. There was a micro. So they likely to be failure for that connection to completely cut off. And so you end up with a diverticulum, which you call Becker's diverticulum. You can have intestinal malrotation, as in during development, when the intestines are going, do remember at around, I think the 10th day, the 10th week, there is what we call physiological herniation. That's the intestines come out and goes back. Yeah. So it may fail to rotate properly, and so you'll have malrotation. Mal means bad rotation, so it rotates badly, so that you have the intestine in the wrong places. You can have what is called intersusception. Basically, intersusception is telescoping of part of the intestine into another part of the intestine. I wish I was there physically. I would have probably drawn what we mean by intersusception. This is quite common and causes intestinal obstruction. It's really common in children, intersusception. Volvulus is rotating of the intestine around itself, especially the intestines that have mesentery. For example, the small intestine, the transverse colon, and even the sigmoid colon. Those are places where twisting can occur. We call it volvulus. And you can cause intestinal obstruction, as you can imagine. Of course, you can have tumors that can affect the small intestine, the large intestine, and can even cause obstruction. You can have worm infestation. For example, we have a common worm we call roundworms. Yeah, Ascaris lumbricoids that I'm sure you'll be able to look at later on in your learning through the years. Which can especially common in children, and it can actually be multiplied, become so much within the intestine that actually causes blockage of the small intestine, especially in children, more common in children. And of course, these are in places worm infestation mostly will be because of poor hygiene, maybe low socioeconomic status. Those are the places where you are likely to have people developing worm infestation.